Welcome to episode 62, Deconstructing Addiction, Is It Really a Brain Disease? Featuring Dr. Mel Pohl, board-certified addiction specialist. From Clearly Clinical, learn, grow, shine. Hello to our listeners. Today, we will be spending some time with Dr. Mel Pohl. Dr. Mel Pohl is an MD, and he is a Distinguished Fellow of the American Society of Addiction Medicine. He is certified by the American Board of Addiction Medicine, and he is a clinical assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Nevada School of Medicine. Mel, thank you so much for joining us today.
Good morning, Beth. I'm happy to be here.
So tell us a little bit more about your background.
Sure. I am a family doctor, and I moved to Las Vegas in 1979 after my residency and took a job working in rehab, an addiction rehab, and kind of fell in love with the field through the back door. I actually, the doctor I went to work for was in charge of the facility, and he said, "Oh, by the way, I've got this work for you here, and every other weekend you're going to be on call." So as a result of that, I spent quite a bit of time in detox and what was to become a pretty decent rehab treatment center. And you could say I fell in love with the field. I mean, it's as you know, so fascinating that such a unique opportunity to treat people in a very vulnerable time and to be really impactful. So over the years, I've been involved with a number of facilities, and for the past 16, I've been at the Las Vegas Recovery Center. We treat addiction and also chronic pain and co-occurring mental disorders in the Las Vegas area. We have a full spectrum of treatment modalities, and that's this is my home, and again, the place I really do the most exciting work. And for the past 2 years, I moved from medical director to chief medical officer so I could do more administrative work and travel and teach more.
Well, thank you for joining us. I'm sure our listeners are excited to hear from you. You have such a strong affiliation with ASAM, and obviously ASAM is so well known in the United States. Thank you for your time.
Sure.
So today we're going to be talking about deconstructing addiction. Is it really a brain disease? Why don't we start just by you talking a little bit about what this topic means to you?
Sure. Well, I've given a version of this talk since the beginning of my career, and I think it's really essential for clients, patients, their families, and clinicians to really understand the nature of the brain disease of addiction. I think it's really important because we have so much stigma associated with addiction. And when a real clear message about the brain dysfunction and the causes and the progression of this process that occurs in the brain, when that is offered, I think it's a real move towards destigmatizing this very complex illness. And I think that you have to understand the brain disease in order, in some capacity, in order to recover as a person with the disease, but also for a family member who cares about such a person. And for every person with addiction, there's at least 5 people who are affected seriously in their family by addiction. And finally, for the clinician who we're talking to today, to really, especially if you're a mental health clinician, to really grasp the significance of the fact that the will is not what's at stake when it comes to addictive behaviors. And I think in order to be effective with somebody who has substance use disorder, which is what the DSM is now calling it, which I'm going to call, through the course of our conversation, I'm going to call it addiction. But that phenomenon has to be well understood, and it has to be treated. I mean, if somebody has mental illness, bipolar, depression, schizophrenia, or anxiety, and they have an addiction disease, they must be offered treatment for the addiction at least concurrently, and maybe first, because if there are chemicals in the brain of somebody who has addiction, it's almost impossible to recover.
Thank you. I know this particular topic is pretty hotly contested in certain communities, coming from either the perspective of diehard 12 step or the biopsychosocial spiritual model and kind of flexibility of disease, the disease model of addiction. What have been your experiences related to kind of that idea of, like, basically, is this a disease? Can we officially call this a disease? And you come from a very experienced perspective as an MD.
Yeah, I don't find the disease, it's referred to as the disease concept or the disease model, but that's just because I think we were sort of somewhat apologizing for, it's kind of a disease. Well, a disease, if you look in the definition in a medical dictionary, it's a process that alters the body's structure or function, diagnosable by signs and symptoms. So, and if you compare addiction to diabetes or cancer or heart disease, they're very parallel in their course, in that they have some etiology. Usually it's multifactorial. In the case of diabetes, there's a genetic propensity, but there's also weight and diet and physical conditioning and other factors that are yet to be defined. And that's really the state of the understanding of addiction. Addiction is a brain disease. Brain dysfunction causes symptoms that are behavioral. So when we try and define the disease, we talk about the lying and the cheating and the stealing and interpersonal relationship problems and work and other functional disorders that go along with. But really, we're talking about the manifestations of what's happening in the brain. Our brain is, of course, in charge of all of our functions, both our mind and our, the part of the nervous system that isn't necessarily conscious, but that's pretty much running the show. And I don't find any conflict with understanding that addiction is a disease and defining it in the sense of a biopsychosocial spiritual condition. Because if you think about it, there is no disease known to humans that is not biopsychosocial and spiritual. Again, look at diabetes. If you define the disease of diabetes, it's pancreas related dysfunction and insulin that doesn't work right and a whole lot of other complex interactions with the hormone system. But there's a psychological component to diabetes with frustration and fear and anger. There's social issues around use of medications and compliance with treatment recommendations and the course of one's life as a result of the diabetes with complications. It could be visual complications and kidney complications. And there's a spiritual component to diabetes. People are soul sick, if you will, with their separation from well-being. And I think we could say that about every single medical disease. I think addiction, in its definition, and the definition that I like the best is provided by the American Society of Addiction Medicine, but it really talks about the biopsychosocial and spiritual manifestations of this brain disease. But again, that doesn't make it less of a disease. The fact that there's a spiritual component to a disease is something that the medical profession is in denial with, I think, with respect to other medical diseases. I think we're ahead of the game when we understand the spiritual component. And as I'm sure most of your listeners know, is in the 12-step programs, I think they embrace the fact that addiction is a disease. It's referred to in the big book of Alcoholics Anonymous as an allergy, which isn't physiologically correct, but it's good enough to understand that if I eat strawberries, I break out in a rash. If I drink alcohol or I use opiates, or I take marijuana, it causes a chemical reaction in my body, electrochemical reaction, if you will, and I end up having these behaviors, which are symptoms of the disease.
I can certainly appreciate the perspective of how the spiritual and social pieces fit into the disease model of addiction. And having sat with families before, I think where I see a lot of pushback or confusion about the quote unquote disease model of addiction is this idea that by calling it a disease, some folks have interpreted that to mean that individuals are no longer responsible for their actions.
Yeah.
And I think you mentioned that piece of lying, stealing, cheating, these behaviors that happen in social relationships that are so difficult for loved ones, employers, family members, even neighbors, things like that, to understand in society. And yet it's still rooted in this brain dysfunction effectively.
Yeah, I mean, I run the medical part of family program here at Las Vegas Recovery Center for the last 15 years, and so once a month I sit with families, and it's really quite interesting. Some of them come with some understanding, and some of them come with confusion, and some of them come just downright pissed off. How dare you let them off the hook? And of course, during the course of the 4-day family program, we work with their anger and their resentments, because those are the things that are making the family member sick. But that said, in my experience, the resistance to absolving somebody of responsibility is an unrealistic one. We don't really feel. I don't feel as a physician that if let's go back to diabetes. If somebody is eating excessively and their blood sugar's out of control and they get sick and they throw up on your shoes, I mean, those behaviors are abhorrent, but understanding that they're doing all that because they have a compulsion to eat as part of, perhaps even an addictive disorder, of course, with compulsive eating in the face of diabetes. But it's a very similar process, and the responsibility remains in the province of the patient or the identified person with addiction, but the understanding of why they behave the way they behave is key to being able to even move past the anger phase. And I mean, I hold patients, and we recommend that families hold patients responsible for their actions and the consequences of their actions. For example, if you stole, I mean, even in Alcoholics Anonymous, they say the 8th step is making amends. You pay that money back. The other side of the coin is, of course, forgiveness sets you free from the awful burden of being angry and being resentful at what the person did. But understanding that all of those behaviors were a manifestation of the fact that addictive substances became more important than morality and promises and appropriate behavior. And that's the essence of understanding the disease.
I appreciate that explanation. And as you're talking about it, I'm thinking even about animal studies
Mm-hmm.
relating to addictive disorders. Can you speak a little bit about what some of the animal studies have found in terms of behavior change and alterations in social relationships, even within animals?
Sure. Well, it's nice to look at animals because we can't attribute human behavior and emotions to animals. They're not motivated by greed and jealousy and right and wrong. Animals are creatures that drive towards things that are rewarding without any kind of discernment. Humans have that ability to discern, which comes from our frontal cortex, the area, the sophisticated new brain that really guides a lot of our actions. But addictive behaviors, which are present both in humans and in animals, come from a much more grounded reptilian sort of a function, which is, feed me. I need food to get my blood glucose up, or my brain will be deprived of glucose. Sex to reproduce. My need is to create more progeny from my genetic pool. That's my purpose in life. And when it's all done, I sleep. And all of those functions are part of that very intrinsic, primal function of the brain present in animals. And we can induce addictive behavior in animals by exposing them to particular drugs. For example, the traditional, the most well-known study is the rat that's given an opportunity to eat, and a male rat has access to a female rat in heat, or a jolt dose of cocaine into the midbrain, the part of the brain that we know is affected by drugs of addictive drugs. And if the rat discovers the cocaine lever, it'll press that lever at the exclusion of eating and drinking and sex until it's dead. So you gotta make some sense out of a behavior that defies reason, logic, even survival instinct. The drug it develops what we call survival salience. So its cocaine is number one above those other functions, when in fact it's not doing what it needs to do to nourish me and to provide sexual outlet, etc. Does that make sense?
Absolutely. So you kind of touched upon it. Why don't you tell us about some of the signs and symptoms of addiction? So there are some of the things that we see in rats. What do we see in humans?
Well, we define, one of the ways to define the disease is continued use despite consequences in life. So the symptoms of using substances are in that bio, psycho, social, and spiritual area. But so if you start with bio, I'm talking about alcohol as a prototype of substances that cause or that are involved in addiction. I hesitate to say cause addiction, because it's the substance plus the human's brain that results in addictive disease. So, it's not the drug alone, because if it was the drug alone, then everybody who drank would have alcohol addiction, and they don't. So it's the substance plus the substrate, if you will, which is the human body, brain, background, genetics, etc. And alcohol as a prototype of other drugs, which would include opiate, painkillers, heroin down to hydrocodone and codeine, marijuana, cannabinoids, particularly these very potent edible forms, or concentrated smokable forms called dabbing, or wax, and sedative drugs like the Valium and Xanax, using the brand names for diazepam and alprazolam, and sleeping medications, Zolpidem or Ambien, and what am I leaving out? Cocaine, stimulants. So cocaine and methamphetamine being the two primary substances. So substances are the vehicle that activates the disease, if you will, in a vulnerable person or vulnerable brain. And when the drug becomes primary, everything else seems to go by the wayside. So if you take a drug like alcohol, it's toxic to really every cell of the body. So there is actually brain dysfunction as a result of chronic alcohol use, and cognitive problems and memory problems. There is problems with the liver, as we well know, with fatty infiltration and eventually cirrhosis in the long run. There's trouble in the gastrointestinal tract with inflammation of the lining of the stomach and ulcers, which can cause bleeding. There are increase in different kinds of cancer. Breast cancer is increased, colon cancer increased in people who drink excessively. Kidneys are affected, cardiac muscle is affected. As I said, every organ of the body is impacted by by alcohol. If we stay with physical, look at stimulants. I mean, stimulants are causing the heart to beat fast and all the things that go along with that, which include heart disease and cardiac events like a heart attack or a stroke can be exacerbated or caused really by stimulant drugs. And then there's a lot of neglect of self-care. The typical methamphetamine addict has terrible teeth because they grind and they don't care for their oral hygiene, etc. There's a propensity to infections with a variety of different drugs, particularly if they're being injected. So heroin can be injected or other opiates, and certainly methamphetamine and cocaine. If you're putting a needle through the skin, you can be subject to local skin infection, or worse still, systemic infections like hepatitis or HIV or cardiac infections. As we go down the list, psychological problems that are really compounded in all the drugs that I listed could be anxiety and depression and sleep disorders. With the stimulants, paranoia is pretty typical, and really problems with thoughts. Marijuana, the newest version of marijuana that we see in dispensaries these days, is known for causing psychosis in young people and also in people in their late 20s, early 30s, de novo. So, people who don't have any schizophrenic history or thought disorder history are developing acute psychosis and chronic psychosis. It's very recalcitrant to treatment. Social problems. I mean, people don't fulfill their obligations, so they have significant problems in managing life and managing relationships, of course. So, we see significant stressors in marriages and friendships, in work-related activities, both from impairment at work. You come to work stoned, you can't do your work, you drive under intoxication. There are consequences that are in the legal system. And then there's the just sort of isolation from friends and family as a result of chronic use of substances. And then finally, spiritual manifestations, and I have no interest in exploring religion on this talk, but spirituality really starts with anything other than me, in my understanding. So it really, the isolation and the disconnection that results from chronic use of substances is it's common and really sort of one of the hallmarks of the disease of addiction. People are disconnected from their sense of self. They're very self-centered, so they're looking out for what seems to be their well-being, but in actual fact is counterproductive for their well-being.
All of these factors create, I don't know if I'd say create addiction, but so tell me how you see kind of the relationship between substance and whether that caused addiction, or what you said earlier, which was basically the substance almost turns it on, that there's this propensity for addiction, and then exposure to the substance creates this problem that there otherwise wouldn't have been.
Yeah, turns it on is a good, or activates is a good description of how I understand what happens in the brain. I mean, there is sort of a setup, if you will. And there's been some study and quite a bit of debate about what in the environment results in people being addicted. People in Vietnam used heroin in an addictive fashion, and yet they left the environment of Vietnam when the stress went away, and the incidence of heroin addiction that continued was pretty low. So that suggests that it was the environmental stressors that were the key precipitant. And then there's the classic rat park studies where they put rats in a deprived environment, give them substances, and they become addicted. Put rats in a rich environment called rat park where they get to play and they get to interact and they get, that spiritual connection for the rats. and the result is a lower incidence of use of substances. There are some social scientists who would like to say that is addiction. That explains it totally. I don't get that, Elizabeth. I mean, it's like when you look at the pictures of the brain and you look at the studies that show the activation of certain parts of the brain when drugs are used, it's just confounding to me that somebody would not acknowledge that that's what's really happening in the underlying process of the disease of addiction. But the description that I rattled off, with all those symptoms, are results of use in a vulnerable person. So, people who have a cocktail with dinner don't have those kinds of results. People who drive under intoxication and maybe they get stopped, they never drive under intoxication again if they don't have this disease. They're able to process, learn, change behavior in response to the consequences. The key in somebody who has addiction is because the drug has now superseded the things that foretell well-being, the drug becomes the drive. And the fact that I got a DUI just tells me I should drive on the side streets instead of the highway. Or, I had a patient who truly said to me, after my third DUI, I knew exactly what to do. I sold my car. So, a reasoning person, and even someone with addiction who looks back at their behavior says, this doesn't make any sense at all. In fact, one of the exercises I do with people who have addiction is I ask them to describe the disease, and they'll describe one of the key phenomena, which is the reasons I use substances. So most patients use substances for one of two reasons. They use it to get high, which is to elevate their mood. But the vast majority of people, especially as the disease progresses over time, the vast majority of people are using substances to escape, to get relief from a long list of symptoms like anxiety and depression and fear and anger and relationship problems and stress at work and financial complications and physical problems. And I do the exercise on a blackboard or a grease board. And what it turns out is that the reasons for use are the same as the consequences of the disease. So here I am using substances to relieve my anxiety, and it causes more anxiety. I have more anxiety, so I use more substances to attempt to relieve it. And, it's this futile, ineffective methodology, but in the life of the person who has addiction, there's no logic, because the logic is coming from a part of the brain that's not really activated when the disease is in action. The logic comes from the frontal lobe. The addictive behaviors and drives come from this much more primitive part of the brain that I talked about earlier, with serotonin and dopamine pathways that are really after reward and relief from pain, which was in that area as well.
There's kind of a rabbit hole to go down, and I want to go down it just a little bit. So we're looking at this idea of substance addiction. And one thing that I've seen in my practice, and we don't have polysubstance dependence anymore in the DSM the way that we did, but looking at someone who has a history of polysubstance use. So what I've seen is sometimes some of those folks will have access to a certain substance, use that, and then when access isn't available anymore, then they move on to a different substance, whatever that might be. And then there's also this capacity to move into then the process or behavioral addictions. How do you make that leap in your role with your background between addiction to a substance and then what appears to be an addictive behavior relating to sex, gambling, shopping, whatever that might be?
Yeah. Well, the analogy that I'm sure you've heard and that we use with patients and with families is it's like a game of whack-a-mole.
That's exactly what I was going to say, actually.
Yeah, it's you hit the mole. If anybody was ever in the Midwest carnival, you hit the mole and another one pops up, and you hit that one and another one pops up. We used to call that cross addiction. That I drink alcohol and I give up the alcohol, and my doctor prescribed Librium, and now I'm dependent on Librium and I have an occasional drink. Or I have a cocaine problem and I smoke weed to relax, and why can't I do that? And as you aptly pointed out, the behaviors, certainly gambling is in the DSM, which DSM, by the way, is not my favorite book. I think they really do a disservice in the long run to the definition of the disease of addiction. I think the next version will probably be better. I think this version is a little better than the DSM-4, but we're stuck with it. It's the sort of the Bible for making a diagnosis. But for anybody who wants what I think is a better diagnosis, I would refer them to asam.org, asam.org, for the short definition of addiction, which is about a page long, and the long definition of addiction, which is about 10 to 12 pages, all referenced very heavily with studies that sort of substantiate what we're talking about today. But really, the ASAM definition and the definition that I subscribe to is that it's a brain disease related to motivation, memory-related circuitry. That's the essence of the disease, not the behaviors that we see that are manifestations of the disease, if that makes sense.
That does make sense.
Getting back to your question about behaviors are all driven by that same reward system. So the behavior that we talked about to seek food is about nourishment to satisfy the glucose need of the cells of the brain. When we eat to excess, that reward system is distorted in some way. The drive for food is overvalued, and it becomes automatic, and it becomes less about, I want this thing to eat, as eat more, continue to eat more. And one of the things I don't think we've yet talked about is one of the hallmarks of addiction is the loss of control. Give me a little and I want more. Give me more and I want even more. There's never enough. And the desire for more is triggered by a little bit. So, the typical eating behavior is I have one bite of the hot fudge sundae, and the next thing I know, I'm going to the donut store for a dozen at midnight, Krispy Kremes at midnight. And that's, of course, one of the versions of an eating disorder, which is in some understanding a manifestation of the brain dysfunction, very similar and parallel to chemical addiction. Even more similar is a disease like gambling, or a behavior like gambling. And gambling has been shown in really extensive studies to do just about the same thing as cocaine to the stimulation of release of dopamine. And dopamine, of course, is the neurotransmitter of well-being. That's kind of what we all want as much as we can whenever we get it. And it's the drive for dopamine that goes awry that's involved in addictive disorders. And it looks like it's awry, certainly with gambling. It gets a little more complex when we get to things like sex and spending and video games. Clearly, there's a dopamine effect in all of those. How parallel or similar or, is the process exactly the same? I think not in my clinical experience. And of course, we're challenged with the treatment of addiction. The appropriate treatment of addiction in a loss of control process is don't have any. That's abstinence. And the inability to abstain is one of the defining factors in the ASAM definition. For food and for sex and love and for spending, acquiring things, it's really tough to define an abstaining line. So when we talk about treatment, we can refer people to abstain from the type of behavior, that compulsive eating, recurrent eating despite, perseverating thoughts around eating, but we can't tell them not to eat, and the Weight Watchers, which is sort of an offshoot of Alcoholics Anonymous, has an abstinence component to it where the members don't eat white flour or sugar. And it's a tough program to succeed at. So I guess what I would say is there are certain parallels and similarities between behavioral addictions and chemical addiction, but it's not a quid pro quo equal. I don't think it's well enough understood to say that it's exactly the same process.
I can really appreciate that definition, and having worked with some clients that have struggled with gambling addiction and doing quite a bit of research in it, recognizing that it's so severe and that folks with an addiction to gambling type behaviors have such a high suicide risk, are at very high risk of being in abusive relationships, that to me, it suddenly jumped out these pretty clear parallels between what was happening with the substance and what was happening with gambling. And I can see what you're saying about the relationship to these other um, physiological drives like sex, like eating, that we all need to do those things. We don't all need to gamble. We don't all need to play video games. It's once that that disease, if you will, is activated, that suddenly things go awry.
Yeah, it's very complicated. I mean, gambling is interesting. The gambling addiction, as I'm sure you know, starts with the first win. You know, I live in Las Vegas, so I'm no stranger to slot machines, although I don't play them ever because I learned a while back that was not. I just don't like throwing money into a machine. But that said, the win, the sound of the dinging and the cash that you acquire is the beginning of the process of addiction. Just like the first high for somebody who injects heroin or who takes their first drink and has a monumental experience is the beginning of the addictive process. So it's the drive towards the reward at first, which is dopamine, and then it becomes, as I said, the drive away from the negative that sustains the addictive behavior despite the consequences.
You bring up an important point too there that I want to ask about. So tell us a little bit about the addictiveness of different substances. We hear this substance is particularly addictive, or some people get addicted to this, and all of this started, I'd say, with a really clear evaluation of nicotine. Of first looking at this thing that had come out on the market, and then all of a sudden everybody's doing it and they can't stop. What do you see? What are some of the research about the fundamental addictiveness of certain substances?
Yeah. So I didn't mention nicotine under stimulants, but it needs to be there, of course. The addictive nature of the substance is how well it works and how quickly it works. So the quicker it gets into the brain, the more likely to be addictive. So that means short-acting, fast-on drugs are more likely to be addicting than long-acting drugs. And the best example is Xanax, which comes on really quickly and leaves really quickly, compared to Klonopin, which is very slow on and very slow off. Xanax is more addicting in its function. The nicotine is a mild stimulant compared to cocaine. If you look at the amount of dopamine that surges when you inhale nicotine, but the key there is that you're inhaling it. So inhalation is 6 to 8 seconds into the brain. So smoking a drug is a much more addicting manner of ingesting a drug than swallowing it or snorting it, because it has to go through a bunch of different barriers and circuits. So cocaine, if you use it intranasally, which is the sort of the oldest fashioned way, snorted into the nose, it's a pretty slow on process. If you smoke it, freebasing it, or using crack cocaine, it's extraordinarily rapid. And cocaine itself is the effect, as I said, it's the effect plus the on. The effect of cocaine is intense. I mean, if you look at a diagram of how much dopamine is released with a blast of cocaine, especially if it's smoked or injected, it's like 1,000 times the stimulus for food and 100 times the stimulus for sex. So, the addictive nature of the drug cocaine is very high. The addictive nature of smoking or injecting a drug much higher than swallowing or snorting. Marijuana's, I have to mention it again because it is of grave concern to me because the potency, it's THC, tetrahydrocannabinol is the component of the marijuana plant that's psychoactive primarily. And the THC potency, which means, the strength of the high, of the reward, is much higher now than it used to be. It used to be maybe 3 or 4% pure THC in what people got. Now it's 18 to 20%. Edibles even higher. So, juicy fruit gum and energy drinks that have marijuana in them. And now they have marijuana laced wine and, very concerning forms, much higher potency. And then there's a way to sort of distill using butane the marijuana into essentially a hash oil. And that oil is as high as 80 to 90% pure. And that's smoked typically in vapes or pens that are now available as a vape product. And these are drugs that are being used in schools and on the street, and sometimes in treatment centers. It's not uncommon for a youngster to come in and try and get away with using while they're in treatment. So the addictive nature of the current crop of what we get for marijuana is extremely high, and it's smoked for the most part. So at least with the dabs or the wax, the onset is going to be extremely rapid and therefore highly addicting.
How about other substances like methamphetamine or any of the painkillers?
So methamphetamine, very, very high potency, similar in many ways to cocaine. There's a difference in the high that really mostly the addict can tell you about, the person who's injecting. They say meth is it, cocaine sucks, or cocaine is it, and I don't like meth because it makes me feel bad. The main difference is methamphetamine lasts a whole lot longer than cocaine. But the onset of this very potent stimulus, methamphetamine, if you're snorting it, is going to be slower. If you're smoking it or injecting it, it's going to be very fast. So meth would be one of those that goes in the very high risk category, along with smoked cocaine. And then we get to the opiates. And just to say, marijuana, which is smoked, is also going to be in that high risk category. Alcohol has an intoxicating effect, but it's a whole lot milder if you look on the scale than some of the other drugs we've been talking about. And it's typically ingested. So if you're swallowing alcohol, the addictive nature of that drug is in a lower category compared to smoking meth. And then the other category that I haven't talked about yet is opioids, starting with prescription opioids like codeine and hydrocodone and oxycodone and morphine and methadone, but that sort of falls in a little bit different category. But the pills or the oral form of an opiate comes on slowly, so it is less addicting. The problem is if it's dissolved and smoked or injected, which it can be in any of the pill forms, can be crushed up and injected, or certainly heroin is injectable, very fast on. Heroin, if you look at the potency scale, heroin's the most potent opioid. Oxycodone is extraordinarily potent as well. So if you are injecting or smoking oxycodone, which is what was in OxyContin, the addictive nature of that's very high.
We have spent a lot of time in society, obviously, talking more recently about opiates because of the epidemic and how many deaths we've seen related to these substances, and trying to respond to this, things being overprescribed. And you and I have talked about that separately. Tell me a little bit also just about the addictiveness of hallucinogens. That's something that I've seen in my practice. And I think some of our listeners would like to hear that, when we still have things out there that people are using that are kind of an afterthought, that we talk about things like meth, cocaine, opiates, marijuana, but there's this other whole class of drugs that we don't spend that much time talking about.
So if you look at the class of hallucinogens, so we're looking at plant products like mushrooms, uh, which are hallucinogenic, psilocybin, and a variety of cogeners, and LSD, which is a synthetic product. Um, they really work differently. I mean, addiction per se to hallucinogens is quite uncommon. Not impossible, but quite uncommon. So, what I've seen clinically is that hallucinogens usually are part of the picture, but usually it's like, yeah, I tripped once or twice, didn't like it, didn't agree with me, because it's so different experientially than most of the drugs that we're talking about that really activate the reward system. Uh, I don't see primary addiction to hallucinogens as a key phenomenon. Have you seen it as the drug of choice in your patients, or is it more it just kind of comes along with?
Comes along with thinking I have some interesting cases and have had some recently that had exactly what you were talking about with THC, that we had people that otherwise had no symptoms of any kind of schizophrenia, no family history of psychotic disorders, and they start using marijuana heavily. And then what I've seen is kind of layered on experimentation with hallucinogens. And the next thing you know, they're hospitalized for a week or two because of a really severe psychotic episode. That's what I've seen.
And the protracted psychosis is more often than not marijuana these days. Um, it's uncommon in my clinical experience. I don't know the current literature on hallucinogens, but as you said, it's not something that people are studying very avidly. But for all of it, the the long term nature of inducing psychosis was infrequent compared to what we're seeing with this crop of marijuana, especially in under 25-year-olds. The brain, the structure of the frontal lobe is still developing up until 25, and there's a whole bunch of data that's being accumulated that shows damage to those brains, and some of it probably resulting in psychosis, other resulting in IQ drops and cognitive problems and memory problems and school performance problems.
One of my other questions, now that we've talked a little bit about some of the different drug classifications and what we see in terms of the high and the addictiveness, how do you conceptualize recovery? So now we've talked about the disease. What does recovery look like?
Yeah. Well, as I mentioned right at the onset of the show, recovery has to start with elimination of the drug. Uh, and we probably should put a bullet point there or an asterisk about opiates and medication assisted treatments, because that might be an exception. If we have time, maybe we'll get there. But, for the traditional addiction disease, for alcohol, for stimulants, for sedatives, for marijuana, if you ingest the drug, the brain remains disorganized and remains driven by the drug and not by the natural drive system restored to itself. So elimination of the drug is the first step in recovery, but it's only the first of many steps. I mean, the AA program and all the other mutual health programs based in AA are 12-step programs. And I don't know where exactly that comes from, but it really is, there's a progressive nature of, recovery based in acknowledging. I mean, really, the first step in AA and NA and other 12-step programs is I'm powerless over alcohol and my life's unmanageable. That is understanding this is a brain disease. Powerless means I cannot use willpower. I cannot use self-driven power, because those functions come from the frontal lobe. The desire to use and the craving that comes up in people who aren't using, even though they're abstinent, is part of the midbrain dysfunction. And then most of the process of recovery is restoring sort of a normalcy in function. So if you think back to that whole litany of consequences, and in conjunction with that, reasons for using. So, I mentioned anxiety, anger, fear, depression, relationship problems, work stressors, financial issues, And all of those physical problems, some of them will resolve by eliminating the substance. Alcohol eliminated from the body causes a restoration in many cases of normal function, or at least stabilizes the dysfunction. So, you can have cirrhosis of the liver, stop drinking, and the cirrhosis remains stable, and people get on with their life pretty close to normal. It's by continued use that they continue to damage the body. But the real work of recovery, both on a personal level and from a level of what a professional can do with somebody with addiction, is dealing with life on life's terms, if you will. And that would involve relationships and emotional distress, faulty thinking, cognitive distortions in the terms of CBT. And there are a lot of models of treatment that can be offered to people who have addictive disorders that relate to helping people with thinking, helping people with distress, helping people with motivation. The 8-step and the 12-step programs is one that I think is really important in clinical therapy, which is taking responsibility, making amends to the best of one's ability, and moving on. And then, one of the keys in the recovery process is diffusing that self-centeredness, that it's all about me, and recreating, or for some creating for the first time, a sense of community and a sense of interaction with others, and really working towards being of service to others. Being helpful is the 12th step, and probably the most valuable thing that anybody with the disease of addiction can do is get past their own issues and be of service to somebody else. And that's just as simply as making a phone call, or driving somebody to a meeting, or going out for coffee and listening instead of just dumping. The bottom line is, this is, we talk about recovery-oriented systems of care and recovery capital, the movement that's really sort of afoot, which is all about changing just about everything. And really every area of life needs to be assessed, and usually in somebody who has addictive disease has to be reorganized to look outward instead of inward, and to really have some resources for personal self-efficacy, but also involvement with others and being of service. That's a real quick summary of recovery.
I appreciate that. And it's interesting too, because when we're looking at other disorders, we know that involvement in larger purposes, whether that's working in a nonprofit or donating time, volunteering, donating resources, whatever that is, can help people feel better and make us feel more connected. And it's interesting, kind of the relationship between feeling like we're part of something, feeling connected. I mean, the same research basically that came out of Rat Park. When we have others around us and we feel like we're part of something, then we don't feel as driven to do these self-destructive behaviors, whether that's addictive or it's not getting out of bed or whatever it is that is making us not be as satisfied with our lives.
Or eating too much if you're a diabetic, or so, I mean, I might refer to that as spiritual, even though it's, non-religious, but it is something related to a bigger purpose. And I totally agree that I won't say it has to be a part of recovery, but certainly optimal recovery would embrace that higher purpose, however it's acquired. And, the setup in the 12-step programs is that it's built in. When you get to the 12th step, the essence is I'm going to give back, and I'm going to help others the way I was helped through my early part of recovery. And, the other thing to point out is that people coming into recovery early are so shame-based and so guilty for all the things they've done. One of the reasons yelling at somebody who has addiction is so ineffective is because they're yelling at themselves all the time. I mean, there's no, except maybe an antisocial personality disorder in conjunction with addiction, but most people who have addiction are miserable. It's not like they're out there having a good time. They their ambivalence is present. They want to get better. They don't want to keep doing these terrible things. Assuming they have some moral compass, they're going against their morality. So the earliest part of recovery is hooking up with other people, seeing other people similar to me, but also seeing other people similar to me getting well, and sort of identifying with, they have something I want and I can get that. And once I get a little bit of that, then I have something to give to somebody else.
Again, it comes up that idea of connection, social and spiritual coming in.
Yes. Yes.
One of the other things that I've been thinking about, and we don't have a ton of time to talk about it today, but I'd love to open it up. What about the relapse rate? One thing that I hear from families and working with addictive disorders is, basically if they got better, then they wouldn't have relapsed. And I'd love to hear how you approach that and explain that in the context of the disease model.
Yeah, I actually just got a call from a former client who wants to talk about that. The client hasn't relapsed, but he wants to know what to expect. She's 2 years out of treatment, not using, having a better life, but he wants more information about what to expect. Let's start with relapse. Relapse is a symptom of the disease of addiction, just like it is the symptom of a disease of diabetes. If you have an exacerbation or you get an infection, or you overeat, or you run down, you might have an exacerbation of your diabetes. If you disconnect from the things that are effective in your recovery, you would be more likely to be subject to using in response to craving. Craving is, as I mentioned, a symptom of the midbrain disease of addiction. And craving is not, it might come on just because it's Tuesday, but it also comes on because of stress, anxiety, fear, depression. So theoretically, adequately addressing those issues ongoingly is the effective treatment and prevention of relapse. But we know that people relapse. When I ask groups of, particularly families, is relapse part of recovery? And the answer is no, it's not. Relapse is not a part of recovery. Relapse is a manifestation of the disease, but relapse is truly stepping away from recovery. Recovery, as all of us know, is only a day at a time. There's no guarantees for long-term anything. But in response to your question about data, we just don't have data about relapse rates. I think good treatment provides long-term abstinence opportunities for all of their clients, and perhaps a good running start for as many as 50 to 70% of those clients. How many people sustain that benefit really relies on what plans are made for them on an ongoing basis. Because relapse, of course, can happen in 6 months, a year, 2 years, 10 years. And the research is flawed in that area. We just, we're unable to find people and we're unable to track them adequately. So we just don't know how well we're doing.
I think that's one of the hard parts of working in this industry is the realities of relapse, and also not being able to have a longitudinal perspective on treatment gains. And when I've looked at the research between the relapse rate, say, of addiction to opiates versus the relapse rate of diabetes or heart disease, or basically this chronic illness that's being managed, and then whatever's being done to manage it is no longer effective. So there's this bloom again of symptomatology. I've seen this correlation that I think is important to note in recognizing that something that may have been effective for a certain time, the body changes, life changes, and maybe we need to go back to the drawing board to come up with a treatment plan that now is appropriate and may be more effective since the factors have been altered.
Yeah, I just before we end, I want to point out that we've got some really good data on physicians in recovery. So these are doctors who are, highly motivated, usually socioeconomically benefited, who are in a very tight monitoring program. And the abstinence rates, including for opiates, is as high as 90% at 7 years. So we can do that. And the key components of that recovery is really maintenance and accountability. So there's food to be learned. There's information to be learned from that population and from the drug court population. But that said, the collection of data, the availability of data is really pitiful, and I don't know how we're going to get past that.
Maybe that's another topic for a podcast, and we have more information on it and can speak more from an educated physician. Um, well, thank you, Mel. We really appreciate your time in what you brought to the table today, talking about the disease model addiction, as well as some of the drug classifications, how that looks when we're looking at it as a disease and what symptoms we see, but then also what is recovery and how do we work toward that and maintain it. I think all of that's been very helpful. Dr. Pohl, how do our listeners learn more about you, about your background, and also other resources if they have further reading that they'd like to do on these topics?
Sure. Well, the website here is lasvegasrecovery.com. Has a lot of information about both me and links to a variety of areas and some things that I've written. I have a number of books. Most of them are focused on chronic pain, the Pain Antidote, and A Day Without Pain, and then a workbook called Pain Recovery, which is what we use here for our patients with pain. There are a couple of other book titles. One is by Dr. Paul Earley, Earley, Recovery Mind. He has a great, probably the best explanation I've ever seen of just what we've been talking about, and has a wonderful model of a recovery system. And then there's the Recovery Handbook by Dr. Al Mooney, Mooney, which also defines addiction in really good terms. So those are some good resources.
Thank you, Dr. Pohl. We really appreciate your time today, and we'll certainly look at those resources. I think this has been enormously helpful, I know, for me and for my listeners. So thank you again.
Great. Thank you.
You've just finished listening to another exclusive continuing ed podcast by Clearly Clinical. If you like what you just heard and you need continuing ed credits, please visit us at clearlyclinical.com to check out our one-year membership, where you'll have access to our growing library of continuing ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.